Welcome to Thinking Thoracic, the podcast dedicated to exploring the advancements in thoracic surgery. Brought to you by the Society of Thoracic Surgeons. This podcast features leading thoracic surgeons discussing and debating the latest research, surgical techniques, and trends to expand your knowledge, challenge your thinking, and help you stay ahead of the curve. Whether you're a thoracic surgeon, advanced practice provider, researcher, or industry professional, Thinking Thoracic is for you. Let's get started. The Society of Thoracic Surgeons Thinking Thoracic podcast is sponsored by AstraZeneca.
Hi, everyone, and welcome to Thinking Thoracic, an STS podcast. I'm your host, Erin Gillaspie, and it's my absolute pleasure to welcome you. I'm so excited to bring you the latest and greatest in thoracic surgery. Today, I am so delighted to be joining you with an amazing colleague, Josh Royce. Dr. Royce is a thoracic medical oncologist at MedStar Georgetown University Hospital. He also serves as an assistant professor in the Department of Medicine at Georgetown University Medical Center. He specializes in lung cancer and has a special focus on mesothelioma. And he works incorporating novel concepts and groundbreaking science to help develop innovative clinical trials in a space that is too often forgotten. It's so great that we get to talk about mesothelioma, thymic tumors. He has won unbelievable awards from the American Society of Clinical Oncology for his research. And I could not be more grateful that you are joining me today to chat mesothelioma.
Thank you so much, Erin, for that really wonderful introduction. Excited to be here and get into the weeds.
So for our amazing listeners, malignant pleural mesothelioma remains a very, very aggressive inflammatory cancer. It's most commonly associated with prior asbestos exposure. I think that's where most people become really familiar with it. And despite really some extraordinary advancements that we've seen across the board in lung cancer, mesothelioma has lagged a little bit behind. And I think it's partially due to the rarity of the disease, the complexity of management. And unfortunately, despite really heroic efforts, survival remains less than we would all like it to be.
Yeah, no, you really hit the nail on the head. I think all those factors really come into play. A rarer malignancy, because of that, oftentimes it is not at the top of the therapeutic strategies for pharmaceutical companies either, investment strategies. And so, you really need multi-institutional, multidisciplinary collaboration to really bring people together to ask the important questions we need to move the field forward.
Absolutely. So this is a thoracic surgery podcast, but I think it's so important that all of the thoracic surgery listeners know what's going on in the landscape sort of around surgery, right? Because it's changing and evolving so quickly. And a lot of the things that we see in the metastatic space very quickly are transitioning and trickling down into the earlier stage space. And to me, when I think about mesothelioma, one of the really big trials that I think really changed how a lot of people were thinking about mesothelioma was the Checkmate 743 trial.
Yeah, I completely agree with you. And it was really, I think, one of the first approvals in the mesothelioma space, and I want to say over a decade. Again, speaking toward kind of the, unfortunate, I would say, lack of development and innovation in the space. So we were very excited to see the results of the Checkmate 743 study. Obviously, this is a trial that looked at combination immunotherapy, so nivolumab plus ipilimumab, versus platinum doublet chemotherapy in unresectable diffuse pleural mesothelioma. The study met its overall survival endpoint. Now, we could really get into the fine details. There was probably a bit of a more differential benefit among histologies. So, the main histologies for mesothelioma are your epithelioid histology, most common, sarcomatoid histology, and then biphasic, which is really everything in between. So the more common histology is the epithelioid histology. There, I would say the differential benefit was not as pronounced. It's not that a benefit wasn't seen. Numerically, the survival was higher with combination immunotherapy than with platinum doublet chemotherapy, but it wasn't the same magnitude of benefit that was seen in sarcomatoid and biphasic, primarily because chemotherapy in that histology really does not perform well. So that was where probably the largest differential impact was seen. But overall, again, a positive study with a survival benefit across the board for diffuse pleural mesothelioma.
Now, Josh, one of the things that has been very interesting is really, with the exception of mesothelioma, we haven't heard a huge amount about this combination of ipi-nivo in really the non-small cell lung cancer space, right? It was one of the arms of the Checkmate 816 trial. It sort of disappeared very early on. We're starting to hear some of the outcomes of that. But for our listeners, can you talk a little bit about why this combination? Why are we thinking about combining these two different drugs together? How are they different? How are they working synergistically to help fight cancer?
Absolutely. So, this is a combination that is not new. Probably first explored in melanoma. Actually, in general, I would say that the checkpoint blockade immunotherapy probably had initially made, and I'd say overall, has probably made the biggest differential impact in metastatic melanoma, which, used to be a death sentence. And now a large percentage of patients are even cured with advanced melanoma, a larger differential percentage than in non small cell. But I digress. The combination is nivolumab, which is your PD-1 or PD-L1 checkpoint blockade, and then ipilimumab, which is your CTLA-4 blockade. Both are immune checkpoints. Both work a little bit differently, but in a complementary fashion to stimulate the immune system. And it is a combination that is approved in advanced non-small cell lung cancer. And it is a regimen that I would say some of us medical oncologists prefer for certain subsets. So when we're looking, for example, at squamous non-small cell lung cancer that is PD-L1 negative, perhaps that's a combination that may do a little bit better. When we're looking at certain molecular features that may portend resistance to PD-1 checkpoint, your KEAP1 alterations, STK11 alterations, that might be where we're deploying this regimen. But it's not without its own costs and risks. Anytime you combine checkpoint blockade, you also get a higher frequency of some immune-related side effects, higher frequency of more significant, higher grade immune-related side effects, such as your hepatitis, your colitis, but then even scarier ones like myocarditis, which again, it's still not that we see that commonly, but it's enough of an increase where you have to think about it a little bit when you're deploying one of these regimens.
Now, mesothelioma often found sort of late in its pathway, right? Can be very challenging diagnostically. Sometimes it's hard even to find that relationship back to the asbestos. Patients often come in with a fairly high symptom burden by the time they're diagnosed. How are they tolerating these regimens in this Checkmate 743 trial?
Yeah, I would say overall, these regimens are well tolerated. So I know I just went into the what can go wrong, but outside of that, that's really one thing that made immunotherapy so transformative and so incredible is that the day-to-day side effects are overall quite reasonable to manage. You get fatigue, you can get rash, myalgias, arthralgias, but compared to kind of the cyclical nature of fatigue, nausea, vomiting, GI side effects, hair loss that you can see with chemotherapy, you don't really see a lot of that with combination immunotherapy. But to your point, symptom burden can play a role in how we think about deploying specific regimens for our patients with advanced unresectable mesothelioma. I would say it's a combination of looking at symptom burden and also looking at disease histology, which plays roles in which regimen I'm looking to give in the front line for mesothelioma.
Yeah, absolutely. I'm really glad you used the words resectable and unresectable because there's been obviously a lot of controversy for a very long time with how we should define resectability. Really, let's face it, across the spectrum of cancers, we still have arguments about what should be resectable and unresectable in non-small cell. When we look at some of the new consensus documents, even from our major organizations, the whole middle part of every graft is potentially resectable. Mesothelioma has sort of fallen into that category as well. And a lot of people noticed during the pandemic in particular, healthcare access was challenging. We have approvals now for mesothelioma in the more advanced space. And we really saw, immunotherapy that was approved in that metastatic space trickle down into what historically was considered a more resectable patient very, very quickly. even without formalized neoadjuvant regimens. And so we're seeing it deployed in neoadjuvant, we're seeing it deployed in lieu of surgery, we're seeing deployed in adjuvant. Talk to me a little bit about your thoughts and your approach for when you are managing a patient, both sort of historically and now in an era of availability of immune checkpoint inhibitors for mesothelioma. How are you thinking about local control?
Whew, I would say, Erin, that there's probably no more controversial topic than the role of surgery in mesothelioma. You go back, 10 plus years, and there's always been this subset that we think, okay, there are patients that appear to be able to benefit from really an aggressive trimodality approach where you throw in surgery, radiation, and chemotherapy. And the question is, well, how can we see that prospectively? And I'm sure we'll dive into it a little more detail, but the short answer is no. We have not seen prospectively that in large populations of patients that surgery has really moved the needle on survival. There are so many factors at play here, though. It's disease burden, it's patient fitness for surgery, it's the experience of the center where patients are being seen. I think that might even be the most important aspect. I mean, I'm not the surgeon, you are, but I should say I am not a surgeon, comma, you are a surgeon. And I think that I can't speak to the technical challenges that come with these surgeries, but all I can, from my vantage point, this seems like it's incredibly difficult. And so I think all those factors play a role when you're looking at a patient and really considering the role for surgery. And again, with more recent data that I'm sure we're going to discuss, I think is even put a bigger question mark on that question. One second. It's put an even bigger question mark on that topic.
It sure has. And I think you are alluding to the very controversial, publicly debated, I think debate's a nice way. There was full on arguments actually when this trial was first presented at World's Lung a couple of years ago. And it's the Mars 2 trial. So let's chat a little bit about the Mars 2 trial. Just in case there's any listeners who haven't heard about this trial, Eric Lim and colleagues from the NHS, who I think you and I can both agree have really been an extraordinary powerhouse of surgery clinical trialists.
Mm-hmm. Absolutely.
They have done some great trials in the small cell space. They did the incredible randomized trial of open versus minimally invasive surgery for resection of non-small cell lung cancers, definitively establishing that minimally invasive surgery is a superior technique, which is something we all assumed, but nobody had ever proven. And then they decided to tackle mesothelioma with the Mars 2 trial. And they took 335 patients, randomized them 1-to-1 in a phase 3 trial to chemotherapy plus surgery versus chemotherapy alone, which was also very interesting because this was sort of growing in an era where immunotherapy is starting to creep in. So that doesn't get sort of brought in upfront in this trial. And the outcomes, of course, that they looked at were two things. So overall survival and then patient-reported outcomes. And this is where I think some of the original controversy started to creep in. One of the big outcomes was patient-reported outcomes. And what they did is they took a panel of patients and they said, hey, guys, for this magnitude of surgery, what added survival would you deem appropriate to go through sort of the level of quote unquote suffering that surgery is going to do to you to make this surgery worth it? And that was a really interesting tactic because I think we all can agree, super critical to have patients as part of every single conversation of what we do, but very controversial in that what is perhaps acceptable to one society might be very different to a different society, maybe very different to each different patient within a society. Can we make that an outcome?
I think that's an excellent question, or at least can you use it as a benchmark? I think the same thing has been asked in the lung cancer space. I think it's been more relevant in advanced lung cancer about looking at some of the driver mutation patient populations. And if we now, on addition to oral therapy, add systemic therapy, what magnitude of benefit is kind of needed to overcome, I would say, the quality of life advantages that come with just a daily oral therapy. Now, the needle has moved a little further there as we have seen overall survival data really hit. but I think it definitely, I think, can supplement and create a benchmark. But at the same time, uh, if no survival advantage is seen, then to a degree, it's a moot point. And I think that's unfortunately what we saw with Mars too.
Correct. And in fact, the surgical cohort of patients did worse than the chemotherapy alone when they looked at their overall survival data. And so they actually, to your point, said, hey guys, this patient reported outcome, while absolutely critical, is sort of made moot by this overall survival data showing that not only did we not achieve what the patients deemed they needed, but we actually didn't even beat chemotherapy alone.
Exactly.
Now, there was a lot of criticisms of this trial, right? And some of the biggest ones were centered, even not even taking outcomes into consideration, were just how they structured their inclusion criteria. So patients were meant to have epithelioid only, and they were meant to be early stage resectable, but most of these patients were just staged with a CT scan.
Mhm.
And so more patients crept in that had N1, N2 disease, N3 disease that was unappreciated at the time of enrollment. Patients had invasion into structures that ultimately weren't able to be adequately resected or then were subsequently deemed unresectable for the intention to treat cohorts. And some patients also slipped in who were sarcomatoid and biphasic, which is not historically patients that we would necessarily offer an operation.
Exactly.
And so it made for a lot of controversy when a very brilliant surgeon stood on a stage and said, mesothelioma is no longer a surgical disease. And here's why. And all the surgeons in the crowd are saying, but we don't operate on those patients anyways.
Exactly. And Aaron, let me ask you, do you feel that there was a differential reception and practice change in different areas of the world, really, namely here, in the United States as opposed to elsewhere?
Yeah, so actually I do. And I think I know a little bit more about sort of the European thought process and the American thought process just through conversations that I've been able to have with colleagues, some debates, some surgical meetings, perhaps less so how they've approached things in Asia, but really truly in Europe, they have aggressively moved away from surgery as a local control, deeming the surgery too high risk and not providing patients sufficient benefit. And really citing it as these patients are suffering complications from surgery and we're not helping them, and therefore we shouldn't be doing it. It has been a much more tempered approach, I'd say, in the United States. And I think a big part of that is when a lot of people think about their practices, in particular, some of these surgical giants that we've had in the fields of mesothelioma. Yes, many of the patients live 6 months untreated. They're recurring 18 to 24 months. But when we think about those long-term survivors, those patients that they all have who are 20 years out, who are cured of their mesothelioma, the commonality that all of those patients have is that they received an aggressive local control. And in those centers, they are highly, highly, highly selective in the patients who are being considered for surgery. And so they're getting really thorough staging with CT scan and a PET scan and a mediastinoscopy and laparoscopic abdominal staging with washings and biopsies as indicated. And they're getting very aggressive surgeries in places that are doing very, very high volumes with very highly standardized preoperative and postoperative protocols. Generally, people are doing pleurectomies and decortications, extended pleurectomies and decortications as the preferred surgery. But gosh, it's hard to believe that surgery has completely lost its role if there's an opportunity for local control that can be done effectively in these centers of excellence.
Yeah, I completely agree. I think that there's definitely a lot of important pearls to take away from Mars too.
Yes.
I think it really suggests that if we're going to consider surgery for patients on a case by case basis, first of all, I think they have to know what the data has shown. And while we like to refer to these, I would say these success stories,
Yes.
both probably that we've had personally and also from case series and retrospective analyses. The bottom line is, in large prospective studies, we haven't seen that benefit, and these surgeries are intense. But at the same time, I think approaching it on that patient by patient basis, where where we really have to critically evaluate, take the steps that you mentioned. Because I think at the end of the day, there are patients who benefit from this aggressive local control. And whether that's cure or it's, really minimization of disease burden that leads to a real pronounced duration of progression free or disease free survival that ultimately translates into an overall survival, I think those patients exist.
Well, and especially because when we think about this trial in particular, we're not incorporating all of these new approvals that are coming down the pipelines. And that's what made me so excited to see your talk at World's Lung, where the specific focus was, hey, how do we start incorporating some of these new strategies into the neoadjuvant space in the setting of these highly selected surgical patients? Can we actually start to transform outcomes? Maybe we were missing a subset of patients in that Mars trial that we can think about more creatively and get higher percentages of these really phenomenal long-term survivals for patients. So tell me about your research project. Tell me about this presentation at World Lung. It was absolutely amazing.
Well, thank you so much. Yeah, absolutely. And I'll say this is a trial that I wrote as a fellow. So it was really great to see something shepherded from, my desk as a fellow, writing out a protocol to accrual and ultimately to seeing some results. And it's something I could not have done without my mentors, Patrick Ford, Julie Bramer, Elsa Ignacio, and others at Johns Hopkins. But yes, so, this study really looked at, and it was in an era where we still, we wrote this trial even when neoadjuvant and perioperative immunotherapies were not approved in non-small cell lung cancer, right? We were seeing the emerging feasibility of that. We were seeing single arm and subsequent line studies of immunotherapy in advanced mesothelioma where we were seeing signals. But I would say there was not yet widespread adoption of neoadjuvant or perioperative immunotherapy. I mean, it was a time where, at least in non-small cell lung cancer, right, chemotherapy, whether given before or after surgery, elicited the same magnitude of benefit. And I'd say that the large majority of centers were taking patients straight to surgery and then going on to adjuvant chemotherapy. So it was really a different era. But suffice it to say, seeing the emerging feasibility of immunotherapy in non-small cell lung cancer, we wanted to ask the question, well, what about looking at that in mesothelioma? This was before Mars 2, so surgery was still something that I would say was more universally considered. And so looking at in patients with either biphasic or epithelioid histology who were deemed upfront to be appropriate candidates for surgical resection as assessed by a multidisciplinary team centered on the thoracic surgeon assessing this, were enrolled sequentially to receive either neoadjuvant nivolumab before planned surgery. So that arm was enrolled first, and then patients were enrolled who received neoadjuvant nivolumab plus ipilimumab, followed by surgery, and then appropriate adjuvant therapy as determined by the treating team, chemotherapy, radiation if appropriate, and then additional adjuvant immunotherapy, with primary endpoints really focused on feasibility and safety. Now, we could obviously go into the clinical, some of the emerging, exploratory clinical data, but first and foremost, the idea was, is this a feasible approach?
Yeah.
Oh,
So obviously, immunotherapy, when we first started thinking about moving it into the neoadjuvant space, there was a lot of consternation, right? We all had experiences operating on patients who'd had years of immunotherapy. Things were very, very stuck. There was a lot of fear it was going to make things worse. But thankfully, with all of these neoadjuvant trials emerging, they've really repeatedly shown that surgery can be performed safely. Really don't see changes in perioperative morbidity, mortality, surgery lengths, blood loss, things like that. Are you seeing the same thing with the addition of neoadjuvant immunotherapy in the setting of mesothelioma?
yeah, so for sure. So we enrolled at Johns Hopkins, University of Maryland, and MD Anderson. So large, tertiary care centers, large centers of excellence, where the expertise exists for multidisciplinary management of mesothelioma. And our study found that this was feasible. Over 80% of patients went to surgery who received either neoadjuvant nivolumab or nivolumab plus ipilimumab. And so it did meet that primary endpoint of feasibility and safety. There was only one dose limiting toxicity in both groups, and neither of which precluded surgical resection. So suggesting that, again, it is at the very least feasible to deploy surgical resection after neoadjuvant immunotherapy.
Outstanding. That's a huge deal. So another great place that we can see emerging use of not only nivolumab but the ipi-nivo combo. And I know there was a lot of concern initially with that combination that perhaps it would increase the number of immune-related adverse events, but seems to be very tolerable, especially sort of in the short term that we think about neoadjuvant.
Yeah, exactly. And in our study, granted, again, it was a feasibility study, but patients only received one dose of ipilimumab before surgery. So they received the 3 doses of nivolumab at every 2-week intervals, with one dose of ipilimumab given on that first day, a dose with nivolumab. So we did not see a really prominent uptick in immunotherapy related side effects with that combination group. Now, does that have to do with the limited dosing of ipilimumab? Maybe. Then when you try to look, and again, I want to stress that the clinical data was exploratory. This is a 16 patient cohort treated with nivolumab and a 14 patient cohort treated with nivolumab plus ipilimumab. But the survival signal for the combination plus surgery was, I think, what was probably the most encouraging clinical data point to come out of the study, where we saw numerically the median survival far exceeding what we've seen with combination therapy alone in advanced mesothelioma. Now, again, this is not a randomized phase 3 study. I'm not saying we have to take this as gospel. But again, over half of patients alive in that Nivo-IPI cohort at the data cut point, 8 patients were alive and 5 were disease free. So it does suggest that perhaps there is something there. Now, importantly, and one might ask, well, if the greatest differential benefit was seen with sarcomatoid and biphasic in advanced disease, uh, you know, uh, can we explore that population more for surgical resection? And I will say this study, began accrual before we had the Checkmate 743 data. So, obviously at the time, and I would say still now, sarcomatoid histology, not generally considered resectable. But at the same time, given the greatest magnitude of benefit in the advanced setting for immunotherapy is in the sarcomatoid population, it begs the question, should we also be exploring surgery in that histology?
Yeah, absolutely. Now, here's another question that I think about really often, especially when we think about these sort of borderline resectable patients. I almost even hate to say those words because the amount of like controversy that just the word borderline resectable brings up is massive. But to me, as I see all of these emerging therapies, the targeted therapies, the immunotherapies, the ADCs, the TIGs, all really making their way into the earlier and earlier stage spaces, you, perhaps, this is my bias speaking, but I think I'm operating on more patients than ever because really we are seeing these unexpected responses. And it's so interesting to hear you say, hey, we actually might be opening a door to say we can locally control this a little bit better by adding all of these treatments. Yes, we might actually be ushering in an era where surgery could play a different role than expected, even.
No, absolutely. And I mean, we've definitely seen that in non-small cell lung cancer,
Yeah.
right? I mean, pre-immunotherapy, N2 disease by itself was something where a lot of centers were like, no, we're not operating. We're going to chemoradiation. And we saw that the largest magnitude of benefit in the non-small cell lung cancer perioperative neoadjuvant immunotherapy studies is probably in that N2 population and even the multi-station N2. Now we're looking at, can you convert unresectable to resectable? Can you operate on N3? All these things. So absolutely, I think that we should always be challenging the current dogma of our practice to see how we can help more people, potentially cure more people, but ultimately how we can extend survival, not just in non-small cell lung cancer, but definitely in mesothelioma, which has been so starved for innovation for so long.
Absolutely. So you did this beautiful phase 2 trial. It's completely feasible. You were able to show patients could get through the regimens. They made it to surgery. Are you planning a phase 3 trial? Is that
That
your
is
next step?
so absolutely. I think that's what needs to be done. We just have to find, I would say, the right partnership, both and really think about this critically, right? So it's not only, all right, well, what sponsor can we partner with or what cooperative group, but how should a study like this be done? To your point before about, some of the criticisms of Mars too, how can one avoid those sorts of controversies that might emerge? So is this something where you have to be I think you have to be very selective about sites that are considered, the workup that's done for these patients, the patients that are considered for a surgical study? So personally, I think there is enough evidence that we should pursue a Mars 3 or whatever the next planet in line is, maybe a Jupiter. I don't know. We have to change up the name a little bit. Uh, I think that that has to happen, but it's thinking about it in a critical way so that it can be designed to answer the question that needs to be answered.
Absolutely. And I think really vigorously finding the inclusion criteria to make sure that we're truly evaluating the cohort of patients that we want to be evaluating, answering questions about.
Yeah, and actually, to that point, I want to highlight one other aspect of the study that we've reported on thus far, which
Yeah.
is ctDNA analysis too. So, circulating tumor DNA is something that has played a role in the management of non-small cell lung cancer, primarily to assess for molecular alterations. But obviously, there's emerging data to look at minimal residual disease, to look at changes in circulating tumor DNA in non-small cell lung cancer, and how that can have predictive and prognostic consequences for what we do. In mesothelioma, that has historically been quite challenging because there is a very low rate of non-synonymous mutations in mesothelioma, which makes ctDNA detection by traditional methods quite challenging. So, in working with our all-star collaborator, Dr. Elsa Ignastu, a real leader in liquid biopsies and ctDNA, we were able to demonstrate the feasibility of an approach really detecting circulating tumor DNA in mesothelioma and showing glimmers and again signals of feasibility of can this be utilized potentially down the road to predict who should go to surgery, who's going to have greater differential long-term benefit. I think more so than other tumor types, we really need something that is better than imaging response to
Yes.
predict benefit for mesothelioma. Resist imaging response is what we use for studies across the board in solid tumors. And for tumors like non-small cell lung cancer, that to a degree makes sense, right? You have discrete nodules and lesions that can be easily measured. You can assess the change in those lesions over time relatively predictably and reliably. Mesothelioma, it's so much harder. This is a tumor that grows obviously around the pleural lining. It's one that is very hard to measure. Now, there is a modified resist criteria that's utilized, but still, so many challenges exist. And we actually illustrated in our study how when you attempt to categorize circulating tumor DNA response by imaging response, it's very heterogeneous. And I think further highlights that not only do we need better therapies to really assess the role for surgery, we also need better metrics to assess systemic therapy response so that we know who we should take to surgery. So, I think a lot of potentials, a lot of glimmers of hope, a lot of feasibility questions that will hopefully got the first answer to that can lead to larger perspective studies.
Absolutely. It's funny, we talk a lot about circulating tumor DNA, and I feel like we all are buzzing with excitement about what this can potentially afford our patients from a response to treatment, prognostication, recurrence, during surveillance. When is it going to be ready for prime time? Because that's always what we say. We're like, guys, it's coming, but it's not ready for prime time. When do you think we are going to off clinical trial? And I'm not going to hold you to this, but do you think that's in the next year that we might be using this and incorporating this into our standard practices, or are we still maybe a couple of years out?
So, are we talking mesothelioma or lung cancer or
Lung
across the
cancer in
board?
general, or
Lung
any
cancer in
cancer.
general. Yeah, let's get the hot take. Uh,
That's right.
you know, I will say this.
Yeah.
I think we are already utilizing this a little bit
Yeah.
in the medical oncology space. And I think where it probably has the most relevance and pertinence is for patients who have had curative intent treatment. And we're trying to assess, well, what's the duration of adjuvant therapy that people should be on and for how long? And should they even receive adjuvant therapy? For example, if someone's on an adjuvant targeted therapy or even an adjuvant immunotherapy and then you stop, we should be checking minimal residual disease there to look for any early signs of recurrence. And if we're seeing it, maybe that's a scenario where one needs to be back on a treatment, to attempt to prevent a macroscopic recurrence. I think the metastatic setting is a much more challenging picture. And the reason for that is if somebody has advanced disease that is unfortunately not curable, and we're seeing rising numbers of circulating tumor DNA, but we're seeing stable scans on a therapy where someone's tolerating it well, they're doing well. You know, when do you make that change in treatment? This is a treatment that they're tolerating well. Is another treatment going to be harder to tolerate? Are we just getting lead time bias there? For someone where you can maybe even wait a little longer, get that quality of life benefit a little bit longer till you make a change. So I think we're not at prime time. People are utilizing it somewhat, but I
Yeah.
think it has more potential clinical management ramifications in that localized and locally advanced space.
Yeah, it's a super, super exciting space. And really, we see it making its way. It's a common thread in almost every study coming out right now, which is really exciting. And actually looking at the differences pre-treatment, post-treatment, pre-surgery, post-surgery, I think it's going to potentially inform not only efficacy of a treatment, durability of a treatment, potentially also inform how we need to be doing surgery, which could be a very interesting outcome to it as well, because there's no question we shed tumor DNA during surgery. We're manipulating tumors, moving them around. They all have venous drainage. Most patients are able to clear all of it independently, even without treatment, and in
Mhm.
small exploratory trials by 3 months, but some aren't. And so a lot of really interesting questions keep rising around the circulating tumor DNA that I think is going to change how we all practice.
Yeah, and the technology keeps getting better and better. And so when we get results, so I think it's great that studies are incorporating the collection so that these tests can be done. But then oftentimes you get data back and you're like, oh, well, yeah, but the technology is now better. Yeah, but now we're looking at detecting minimal residual disease at an even smaller level where our sensitivity is even greater. So, I think that that has challenges, obviously, because if you're looking for an approval of some form of biomarker, you need high level data. But it also makes it more exciting because as we get to better levels of detection, hopefully we're able to also design studies better on escalation of therapy, de-escalation of therapy, so that we can, really try to target the right treatments and the right duration of treatments for our patients.
Absolutely. Now, circling back to mesothelioma, which is the big thing we've been chatting about, and your beautiful phase 2 trial, and how we're thinking about incorporating multimodal treatment regimens in an era of immunotherapy and targeted therapies. What percentage of patients are you anticipating after a mesothelioma surgery in this specific context and space of your trial? So these highly selected patients are getting neoadjuvant. What percentage are you expecting are going to need some kind of an adjuvant addition, whether it's additional local control in the form of radiation or additional immunotherapy? Because it is a big surgery. And we struggle sometimes even after lobectomies to get patients
Mhm.
onto adjuvant and onto an entire course of adjuvant. These surgeries, I think, arguably considerably bigger, higher morbidity, higher complication rates. We struggle with things like air leaks afterwards, many of our patients going home with chest tubes, a lot of complexities to manage. So, how do we get these patients set up for you? How many do you think are going to need adjuvant? How do we get them set up for you? How do we maximize these handoffs to make sure we're doing right by our patients?
Yeah, it's a very challenging question. And I think it's tough too, because I think the majority of these patients are probably not cured with surgery, right? It's a macroscopic complete resection, which means we expect there to be residual tumor tissue. It's just a question of, well, if you add on radiation, is there an additional benefit? If you add on more immunotherapy, are we going to see more benefit? Is that dependent on pathologic response, which I will say is something that is incredibly challenging in mesothelioma. We had actually intended to look at that as one of our secondary endpoints to look at pathologic response, as we have with non-small cell lung cancer. But quite analogous to imaging response, pathologic response in mesothelioma is really difficult to assess, kind of given the nature of the tumor. And so I think that's something that requires additional research, additional work to again predict who is more likely to benefit from more aggressive treatments, whether that's more radiation, more immunotherapy, chemotherapy in patients. So we definitely need better biomarkers to predict that.
Oh, that's really interesting about the pathologic assessment of the response. I didn't really think about the implications and the challenges of residual viable tumor when you're looking at it is in sheets as opposed to an actual mass, right? It's a very,
Exactly.
very different way of
Exactly.
looking at things. Oh,
And,
that's
and those who have attempted, I will say there's another study that's been done, led by Michael Offen out of Sloan Kettering, looking at nivolumab plus chemotherapy. And I know that they've attempted to look at pathologic response as well. And again, you just haven't seen that same clear correlation with efficacy that we've seen in non-small cell lung cancer. So that's a question of, is pathologic response not predictive in mesothelioma, or are we just not assessing it appropriately, right? Do we just not know yet how to find the right response markers that translate into long-term benefit?
Wow, that's absolutely fascinating. So many really exciting opportunities for further research in this field and to continue to try to sort out what combination of treatments are going to best serve this incredible patient population.
No, absolutely.
All right, Josh, we've talked about some super exciting things. So, immunotherapy era ushered in with Checkmate 743. We had the Mars, very controversial Mars trial, which brings into question local therapy and control, how we navigate that in the future. Your incredible trial, neoadjuvant, followed by successful resections. What are you most excited about next in the field of mesothelioma?
Yeah, thankfully, we are seeing some glimmers of hope for drug development in mesothelioma. I think two major classes of drugs to be on the lookout in mesothelioma. One is TEAD inhibitors, TEAD inhibition, which is something part of the YAP-TAZ pathway and molecular alteration pathway that we can see is playing a role in mesothelioma. The other are PRMT5 inhibitors and medicines that are involved in the cascade involved in MTAP. So MTAP deletions are an emerging molecular alteration, an emerging therapeutic target in both non-small cell and mesothelioma. And we're seeing emerging studies that these compounds may have a role in mesothelioma. So I think those are two perhaps more targeted therapies. We haven't really been able to talk about targeted therapies in mesothelioma, but maybe we're going to enter that paradigm. And I think that's something that probably holds the most promise. And of course, we're exploring antibody drug conjugates, other novel compounds to see if they can translate to benefit in that space.
Oh, that's so exciting. Really, truly being able to see more drugs moving into every part of the field of mesothelioma, I think is so critical. Do you think we're going to start seeing more studies differentiating the histologic subtypes? It seems that while we always have the intention of having surgery only epithelioid trials or biphasic and advanced stage sarcomatoid phases, but it seems like a lot of them get bunched in together. Do you think in an era of targeted drugs, we're going to start to really see those specific histologic diseases developing completely disparaging pathways?
Yeah, I think it's possible. I think one challenge is you take a rare tumor type, mesothelioma, and then you try to subdivide it into histologic subtypes further. Because I've asked that same question. I've said, whoa, but like what? If you look at sarcomatoid, if you look at this, if you look at that, like, is there a differential benefit? But it's hard because oftentimes those subsets are even smaller, right? The dominant subtype is epithelioid. So you either, particularly from a sponsor's perspective, you either have to focus on the largest subset or you enroll kind of all patients and then look for subsignals there. So I would like to say that we'll see, some differential, trials really targeting unique histologic subsets. I think the more likely scenarios you're going to target those molecular subsets. So, all right, mesothelioma with an MTAP deletion, that's going to go into this bucket, or mesothelioma that has an alteration in the pathway to predict benefit to a TEAD inhibitor, that's going to go there. So I think it's going to be more probably the molecular makeup of the tumor as opposed to the histology that perhaps might guide therapeutic development in the space.
Ah, it's really exciting, really exciting. And I think an important moment to put a call out to everybody listening. If you're taking care of mesothelioma patients and you're passionate about it, make sure that every single patient you're seeing is being considered for a clinical trial, for databases, for any opportunity in mesothelioma to study these patients because it is such a rare disease, can really change the way that we're treating patients in the future.
Absolutely. We need the patients, we need the data. This really all I will also say could not be done without patients, right? The patients who took the chance on a neoadjuvant study before surgery on our trial, patients that are getting enrolled to novel treatments. It's really I would say a kind of a symbiotic relationship of sorts where we need to advance the field. Patients need better treatments. And so, really coming together again, I can't stress enough how much collaboration is important here, particularly in a rare tumor type. We all need to be coming together to think collectively how can we best approach our treatments for these patients.
Absolutely. And continuing to demand that everybody is performing at the highest possible level. And, one of the things we didn't really talk about with the Mars trial, and one of the really unique aspects of that trial that I thought as a surgeon was really extraordinary, is that every single center that participated was a surgical center of excellence. But then every single surgeon had to have a case observation as well, to make sure that they were meeting the absolute surgical standard that clinical trial wanted to design. And to do something like that, for all of those surgeons to be humble enough to say, hey, I'm not only going to be a great surgeon, but I can prove it by having people come watch me. But to hold an entire country to that standard, I think every single clinical trial should be doing that. I think we should all be doing that every single day. I know that's something you guys do in oncology. I know it's something we think about all the time in surgery. I think that was one of the really, really amazing take-home pieces from that trial.
No, and I think that's really incredible too, because that's something that I think in the medical oncology world, it's that's less of a consideration. No one's looking over my shoulder to make sure I press a button right on a computer for ordering an immunotherapy or a chemotherapy, right? But in your field, right, it's not just the procedure, but it's you are really directly responsible for how that procedure goes for the surgical technique, and so I think that that's a very interesting and creative way to try to standardize of sorts a really challenging surgical procedure and make sure that there's a consistent level of experience and expertise that comes with that resection.
Yeah, absolutely. Absolutely. All right. What closing thoughts do you have for our listeners? What key take home points do you want them to leave with today?
Yeah, I'd say the key take home points are that, the field in mesothelioma, like in other tumor types, it's evolving rapidly. I don't think that the door should be closed on surgery in mesothelioma. I think many perhaps looked at that with the Mars 2 study, but again, that was in a pre immunotherapy era. And just as in other tumor types where immunotherapy has truly transformed who we're considering for surgery and really helped advance survival and cures, I think we can't forget about mesothelioma there. And we need to still prospectively evaluate the role that surgery plays in these patients so that we can give everybody the best chance to live the best quality of life and the longest life that they can.
Absolutely. Absolutely. What a perfect take home message for our incredible listeners. Thank you so much, Josh, for spending this time with us. Thank you so much for what you're doing to move the mesothelioma space forward. It really does take passionate people like you to help keep driving this forward, especially because it is such a rare disease. So thank you.
Thank you for having me. This was really a great conversation.
Wishing all of our incredible listeners a wonderful rest of the day. Thank you so much for joining us. Please continue to do all the inspiring work that you do. Don't forget, November is Lung Cancer Awareness Month. So please keep educating people about lung cancer and the importance of screening. Keep taking extraordinary care of patients. Stay passionate. And as always, keep smiling. To our amazing listeners, thank you so much for joining us today. If you have enjoyed the conversation, please be sure to follow Thinking Thoracic on your favorite podcast platform so you never miss an episode. Your support helps us to continue to grow, improve, and to bring you the most insightful conversations. And if you have a moment, we'd love for you to leave a rating or review. It really makes a difference. Thanks for tuning in, and we'll see you next time.
Thank you for joining us on this episode of Thinking Thoracic. The opinions expressed in this podcast are those of the participants and do not necessarily reflect the views of the Society of Thoracic Surgeons.